Data is, depending on who you are, either a dirty subject or the most exciting thing there is. So why don't we just, I want to start off by kind of each of your philosophy in a sentence or two about data. I mean, are you wildly optimistic, or are you worried about privacy, or you are a hybrid of the two? Mona.
I'm wildly realistic. I will say that there is enormous potential. We need to do the hard work of being able to connect information that many times we just haven't connected, and we jump to a lot of advanced analytic techniques. So I would say that that is certainly, from my perspective on what we're doing at the federal government level, that's an enormous focus, that we need to be able to connect sources of information that haven't been connected before. And data, your big data is only as good as your small data and what you're actually able to action on. And so let's build the infrastructure that we need to then be able to take the action that we need.
That's a very well thought out answer. It's good. Yes, John.
I would say I'm wildly optimistic, but very practical about it. I think at the core, what we're trying to do here is all based on the data. And as Mona said, it's not just the size of the data, it's the quality of the data and the context of the data and the relevancy of the data. And in the end, I think the reason we're all talking about artificial intelligence and AI is because that's the only way to extract information and insights out of the mass of unstructured data that we're collecting in healthcare. I mean, we went from just a few years ago, data was doubling every 18, 24 months. Now it's doubling every 7 months, and we can see it doubling every 2 or 3 months. And the only way to get information out is through the use of artificial intelligence. And at IBM, we're big believers in privacy. We have a certain set of standards which says, your data is your data. We tell you when we use artificial intelligence. We tell you how it was trained. And so we're completely transparent about the use of AI as it relates to someone's data.
Gianrico?
In order to show value in healthcare, you need data. So healthcare without data is never going to get better. So it's sine qua non that data and excellence in healthcare go together. I think we've come a long way. We have more to go. But as an institution, Mayo Clinic, that has stored every data point since we started 154 years ago, I can tell you the ability to have data integrity, to show that there's data provenance you can trace back, allows us and allows others to really set the stage for that transformation that AI has been talked about for 30 years, but now we no longer talk about it, well, we still do, but now we actually can do something about it. And it all comes down to what we've just heard, knowing what's important, knowing where the data come from, knowing who allows us to use it and who doesn't, and more importantly, always keeping in mind that data only matters if the outcome is something that matters to our patients.
That's a good point. You know, Mona, you've done a lot trying to integrate different data sources together, but one of the things that I as a clinician see very quickly is that we don't have data standards, we don't have standard data elements, we don't have standard data collection, and so when you're putting these hybrid sources of data together, where you're calling it a broken leg, you're calling it a fractured leg, you're calling it something else, it's very hard to use the sophisticated machine learning and other things because it's not structured in a way that enables that. How do we get to that? Who's going to take the non-sexy stand of data standards and other things?
Well, that would be the ideal job for the federal government, and I think we are trying to do that, right? We are using standards and promoting that both for industry use, but also in how we're approaching our data integration work, and using an ontology-based model to do some of the data integration work that we need to do. It absolutely is the non-glamorous part of all of the work that we're talking about, but it's foundational to everything else. And I think, from my perspective, when we think about HHS and 29 different units, all with very disparate sources of information, you can just say, throw your hands up and say, this is an incredibly complex problem, and where do I even start? Our approach is really to say, okay, we need to identify priorities for our organization that are impacting the health of all Americans that we can get behind, and let's take that use case and build our internal capacity around that use case, and then around the next use case, and over time really build that institutional capacity. Rather than just without having that organizational imperative be the source of how we're approaching this, which would then just be an exercise in cataloging data that doesn't matter.
You know, we saw until a federal employee until yesterday, Scott Gottlieb, you know, went out and actually, for the first time in 2 decades, changed some of the standards for mammogram reporting, et cetera, in a remarkable way. When is that going to happen in a broader sense?
So I think we attribute a lot of potential to data, right? And I think we have to incrementally demonstrate that value as well. And it's a cycle. So the more value that we can demonstrate around some of these use cases, the easier it is to then go back and build some of those standards and have that adoption. And I think that oftentimes people who are embedded in that space, in this space in particular, take the value proposition for their organizations as completely clear, and it's not, and it isn't for the department as well. So the question is, how do you demonstrate that incremental value, and then how do you use that imperative then continue to do that work?
John, I remember it was 2 or 3 years ago, I got a call one evening from Charlie Rose, and he goes, Agus, you wouldn't believe it. I just went and saw IBM Watson, and it's going to transform health. And he was so excited about a 60 Minutes piece he was doing. Mm-hmm. And then we all saw, you know, a little while later, there were these media reports that IBM Watson wasn't working and people were pulling out of it. Where is it now? I mean, how is IBM Watson changing what I do and what a patient experiences?
Well, look, we've made tremendous progress with IBM Watson in healthcare. First of all, let me sort of just frame it. This is a tough problem. We all know the size and scale of this problem and the complexity of what we're trying to do. And fundamentally, what we're trying to do is bring artificial intelligence extracted from data, insights, to whoever's making a decision, whether it's in a payer network or a provider or a clinic or a consumer, to make a better decision. So it's always going to be a human plus a machine trying to make a better decision. So we're trying to augment that decision making. We've made, I think, tremendous progress. I mean, I could go through multiple areas. We do a lot for payers in terms of optimizing plan design based on mining large claims databases. We do a lot at the clinical level, our oncology solutions. Last year, we assisted doctors with 100,000 patients globally, cancer patients, in terms of giving advice on potential protocols to follow for those cancer patients. We know that the oncologists tell us that in many cases they have made changes to the protocol for specific patients. So we know we've got global scale, we know we're having impact on it, and we're trying to go deeper in the lines of cancer, we're trying to go more global to more countries, and to go to more disease states. But this is a big problem globally that we're trying to tackle.
But who's deciding the problems that you target? Who's deciding, you know, what a patient needs, what a clinician needs? Where's that coming from?
So we work in partnership with the largest payers in, you know, globally, the largest companies, the largest clinical facilities, such as partners like Mayo Clinic. A great example, working with Gianrico's team, is in clinical trial matching. So this is a solution whereby matching a cancer patient with a clinical trial takes hours of human time, given the complexity of both the patient and the clinical trials and the thousands of ongoing trials. We have trained Watson in both reading the patient's medical record as well as reading all the clinical trials, and in minutes doing that match. And at Mayo, we've doubled the number of cancer patients that are enrolling in clinical trials. So it's very much in partnership. We know what we know about data and artificial intelligence, but we need the healthcare partners to choose the problems to have the right impact.
So Gianrico, you needed IBM Watson to double the number of patients in clinical trials because clinicians just weren't doing it, or?
Clinical trial matching is, as a science, there's an art to it as well, and a lot of that resides in knowing what is available, but then making sure that within the record there are the exclusion and inclusion criteria. So having...
Look at this, you got Mayo Clinic on your shirt. It's pretty wild.
That's who I work for.
I'm sorry, go ahead.
We were talking? No, so I think what Dr. Kelly was referring to was the fact that we took breast cancer as a cause and found we could actually double the number of patients entering the trials. Fundamentally, it is still a yet to be completely solved problem because there's geography, there's drug availability, there's cost, there are all the other things that come into it. But yes, it's a great example of a healthcare company like Mayo Clinic working with a company like IBM to come up with these solutions.
So you have an interesting background. I mean, obviously from the personalized medicine side and others, and now you're CEO of an institution. So your mission and vision is to apply technology to help patients, to do all of the above. How is this revolution of data on your daily basis? What are you looking at it daily? And how are you going to use the data that you've been generating for 150 years or whatever you said? How are you going to use it to make patient care better?
So it's really about putting powerful tools in the hands of thoughtful people to do greater good. And so if you take that and you then dissect it out, it's what we are working on. The first is that we've talked about the fact that the data has to be clean. A big change that has happened recently is that when we went into big data, most people said, well, it's better not to annotate too deeply because if you annotate too deeply, you lose scale.
Right.
In the last couple of years, annotation is automated to a certain extent that it now allows us to do things with data, broken shoulder versus a fractured shoulder, that we couldn't do before, and that's a big change. We've always had the philosophy is that you partner and you bring everything to a solution that a priori is going to benefit the patient. And when you do that, then you can very easily vet, then you can pilot, then after you pilot, then you can verify, and after verify, you can scale. To scale, we've used a unified data platform. Our unified data platform enables us to push things into the practice right away. And I'll give you a very quick example. This works when physicians don't even know that it's there. It's just a test for them. So there's a particular kidney disease called polycystic kidney disease, where if your kidneys grow to a certain size, you're eligible to use, and you should use a certain medication. So now our physicians can press the button, order the test, and the volume comes in, and if the volume is above 5% increased, then it suggests what you do next. Behind that is all the work to segment, all the work to find textures within the data, all the work to separate fat from other tissue. That's what you have to do, that's what you have to invest in. And the way we've done it is we've embedded engineers into the practice. So we have engineers go in grand rounds, we have engineers go to ward rounds to be part of it, and then we work with partners like IBM and others. And that's how we've been able to cross seamlessly into the practice. I'll stop with where I began, which is that unless you start with an aim of making something relevant for the patient, then you're not going to end up with something that is scalable or in fact even usable.
You know, Mona, machine learning, AI are very powerful tools. Most people don't understand how they work. And so you can get answers, but it's not always clear the answers are real. How are we going to start to identify, who's in charge here in terms of what are the gold standards? What is something that should change practice? How do we avoid another 737 MAX experience where software that we thought was good turns out not to be good?
Well, so I think the federal government obviously has a huge role here, but the role is also to look at what's happening in industry, what's working, and what is potentially scalable. And what I say is that data can really be the vehicle through which we have enormously meaningful public-private partnerships. And we have to lean into that. I think we've been doing a fair bit of that. We are kicking off our AI strategy in collaboration with industry and with stakeholders from across the department, and we'll be having our first convening on that in about 2 weeks to build out the framework for what the HHS strategy should look like, both in being able to have meaningful applications within the department, but also in terms of how do we enable access to information that HHS just potentially is not in a place to be able to leverage, but industry really can. And how do we enable that in a meaningful way? What are the policy levers that we need to be thinking about more proactively? We're really proud of some of our work around the opioid epidemic in partnership with the private sector. I think our partnership with Google in launching the Take Back programs that came out from a HHS hackathon, a product developed about a year ago, was recently launched on Google Maps, and really at scale. That, for me, is one of the examples of the fact that HHS sometimes is not the user of its data and can't even think of the potential solution in the way that our partners can. And certainly in terms of being able to scale some of those solutions, that is also oftentimes we're not in the right position to be able to do that. And so that's sort of my pitch always to folks at the department, which is data is the vehicle for being able to partner to solve some of the most complex problems that are facing this country. And we need to lean into it both from a policy perspective, from our open data work, and also in thinking more proactively around our AI strategy. But again, what I would say is that everything really starts from having the foundation for how you share and connect data, and having data that is the right data to be able to bring to the problem.
So if I said to you, let's build a code of conduct for transparency, an algorithm for sharing of data and others, would the federal government support something like that, you think?
A code of conduct?
Code of conduct is probably the wrong word, but a set of principles of how we have to act here. We need, to get normative behavior change, you need leadership.
Absolutely.
And this space is going here, here, here. We need somebody in charge so we all start to do the right thing to benefit patients.
And I think that's exactly the direction that we're trying to move towards, right? So what my hope is that from this first meeting between industry and some of the HHS individuals is that we understand and we have a better sense of what the current applications are, what some of the potential feasible next places for movement are as well, and coming up with a set of principles that help us guide that strategy. What are things that we're not even thinking about? And what are some of those questions that we need to really dive deep into, whether it's around ethics, whether it's around some of the policy changes that may need to happen in the future. And I think the ethics question and the questions around privacy are really paramount.
That's great. John, one of the critiques about private companies in this space is, hey, it's the patient's data. And so, you may develop insights, et cetera, on the data, but how do we make it available to researchers all over for other patients to benefit, rather than being proprietary to a company when it was my disease and my data? How do you wrestle with those kind of issues?
Well, first of all, we absolutely have to respect the privacy of the patient. That is paramount in my mind. Secondly, to Mona's point, I could build an AI black box that no one could ever get inside and determine how it made that decision. Our policy and practice is not to do that. We are very transparent to the physician about how that machine made that decision. And
to the public or the physician? To any physician.
To any physician, any patient that wants to see it, we tell them exactly who trained that machine, so we're extremely transparent in that. And I think that is the way we have to go. These are the kinds of best practices that we have to reinforce in the industry. We have to usher this technology in responsibly with a constant mindset, to Gianrico's point, which is in the end it's about the patient, and in the end it's about helping the caregiver or the payer make a better decision. And that's partially a government responsibility, but those of us that create the technology have to do that in a responsible way. It's not just the transparency or what we call explainability of the artificial intelligence. We have to monitor those systems to make sure they're not developing inappropriate biases in their decision making. We have to have internal monitors and trigger points that brings a human in when we think that, for instance, the machine may be developing a bias. And those are all technologically possible. But I think it's incumbent upon us that build that kind of technology to do that in partnership with the practitioners and the government.
Gianrico, you run obviously a very large network with docs who have very little IT skills in general. We're not selected out based on that. And we also, in general, aren't great in IT security. And so healthcare data security and privacy are obviously critical. And it's an area that we haven't talked a lot about. I recently had the first case in my clinic where somebody had actually changed a medical record of the patient, and I could have made the wrong decision. And it was a pretty scary event. And if that happened to me once, it's happened many times over, or probably people haven't even realized it.
Yeah. So it comes back to some of the things you were talked about. Adversarial AI is now something that's real. We take it very seriously. We're focused a lot on one, following industry standards. So NIST, CSF, to make sure we're at that level of security. But more than that, it's really about knowing at every point where your data is, where it came from, what the source is, and how does it come together. And when you do that, then you are able to detect either malware or sometimes human error that gets inserted into the process. Part of it is actually education. We have started putting AI into our curricula for our nurses, for our physicians. We have started creating datathons where we get a large company or UIUC as an example that comes in, and a physician and an engineer spend 5 minutes together and then go and spend 5 minutes somebody else. And from them, we've come up with ways to better strengthen our security, but at the same time, invent things. Like from that came, how do you detect lesions that are precancerous for pancreatic cancer? Right. So you use the use case as always to be able to then go and then fortify what you do. There's also the recovery part. We've got to make this as rigid and as a fortress as possible, but you also need to prepare for when something happens as happened to you. Mm-hmm. And we do have a completely different autonomous committee that sits and is able to review anything and is able to intervene separately to make sure that we are actually complying with data standards, which, as you know, are getting increasingly complex because there are different rules in different countries.
Different rules in different countries, new discoveries every day, new biomarkers, new whatever, none of which yet are standardized, but hopefully there'll be a more transparent path. You're creating have created one of the greatest data sets that exists in the world. But is it limited to a researcher at Mayo, or can a researcher at Sloan Kettering say, hey, can I have some colon cancer data points because if they will strengthen mine and give me an insight?
So the answer is yes, after the usual, which you know very well, making sure the usual data protection items are there. But fundamentally, what you ask is, what happens after a unified data platform? And to us, the next step now is Mayo Clinic as a platform. Right. Being able to set up Mayo Clinic as a platform so that we work with like-minded partners in order to elevate healthcare by providing AI at a massive scale. And to do so, you do have to have open access, but more importantly, you also need to make sure that you are really working with the right people who want to do the right thing for the patient.
That's great. And by the way, the socks.
Oh, now you saw them too, huh?
Is, and Mona, you've got no American flags on. What's going on here? John, Mona, I want to thank all of you for being part of this panel. We realize that we are at an amazing time in the history of medicine where data is going to provide insight that will benefit patients in the near term rather than the long term. And the challenge is that we do it right, and that we do it quickly because a patient wants it today and not tomorrow, and that we all work together and share this data so we can have the answers that we all need. So I thank you for being here, and we look forward to continuing the conversations in the hallway and at dinner. And thank you very much.
Thank you.